I'd like to introduce Jens Hillengass.
Thank you very much. It's a great honor and pleasure to be here. That's really what I want to say. For me, it's great to be here and to see that things here work similar as in Germany. I'm used to speak to patients. The problem is in Germany, I try to make jokes. So, yeah. The problem is here, I try to make jokes, no one laughs. I guess they're not that good, but also my English is not that good. So it's really difficult to make jokes in a foreign language. That's one of the first things I learned here. So, and as Greg so really politely said, I'm talking about the boring topic, which is not true. I like it very much. And I've done that for, I think I started in 1999 when I was a medical student. I worked in imaging in myeloma because I'm not smart, so I need a topic I can understand. And so I hope you can come with me on the journey in imaging in multiple myeloma. And I have, usually when you give talks as a doctor, you have to disclose what pharma company is paying you your holiday or whatever. But I have to disclose that I'm here talking about imaging, talking to you and talking about the imaging I understand. And I think it's kind of this. This is a German car. You know about German cars and diesel and stuff, right? No topic at that time. That was the, I'm coming from Heidelberg, and next to Heidelberg, it's another unknown city, which is called Mannheim. And there, Carl Benz invented this car, and it was his wife, talking about caregivers and spouses who support you. She drove this car, this new invention from, I don't know, I think from Mannheim to another unknown city, Pforzheim, but whatever. This is what I'm talking about. And if you, later on, you will hear talks from Monica and from Samuel about nanotechnology in myeloma and imaging and stuff, and this is what you will hear later. So try to stay with me with the old German car, and I don't know what brand that is, but it looks fancy, so I thought it's good. The good thing for me is that they will talk about imaging, and to stay as a German, I have to stick with the cars. They will do imaging in mice. So I'm one step ahead. What I'm doing in research is imaging in humans. So let's jump in. Why is it important to talk about imaging? I guess all the patients here had some kind of imaging in their career. Have I put, oh no, it's working. And there are different kinds of imaging, and they have benefits and challenges, and I would like to introduce them to you. I hope it's not something you already know, because I was told you're the advanced group, and from your questions I really got that that's true. In Germany, I have to admit, and we discussed at the lunch table, if we are ahead or behind in research, and I said it's in some we might be a little bit ahead, in some we might be a little bit behind. It's rather similar, so it was not difficult for me. The easiest step for me was to go on with my research. And X-ray, I took X-ray out in Germany. When I gave this talk in German, I put X-ray out because we don't do it anymore, and I will give you reasons for that. If you still got X-ray, it's okay. Yeah, I'm just telling you we can do better, but I mean that's the topic of all our talks today. We can do better, but it sometimes just takes time to develop and to implement stuff and to convince the people who have to pay for it that they have to pay for it. And so the next step would be computed tomography. What we also have is just to lay the basis here, X-ray is one X-ray beam going through the body being detected on the other side. In the early days it was with films, now it's with digital detectors, which is good. Computed tomography, next step, the beam was not just going from one direction, but going around the body. So you get more pictures from all directions, which was the next step. Another, maybe not next step, but different step was not to use radiation exposure, which is not high, by the way, but still, but use magnetic fields. Meaning you put energy, by this magnet, you put energy into water molecules, so they are more energized, kind of, and then you leave them alone and they fall back because they want to be in a lower energetic state, and then they emit energy which you can again measure. So you get information about how much water is in the tissue you are looking for. And I will certainly show you images for that. And then you can use, again, radioactive, so-called tracers, which are substances that emit radioactive energy, and you can detect. And you put something there, and those people are really doing fancy stuff with that. You put something there that shows you, in what we nowadays use, shows you how much sugar, you put a sugar on this radioactive thing, and then you give it to the patient, and cells that divide very often or very frequently, for example, cancer cells, they take this sugar and eat it, and then you can see where are those cancer cells in the body. And that's those Christmas tree images you can see. I think it's very important to differentiate what can you get out of which imaging technique. I mean, we could say PET-CT is the newest one, maybe that's the best. But you have benefits and challenges for all of them, and I will come back to that. Important in myeloma, as most of you will have sadly experienced, the bone. It's one of the main symptoms. Nearly every patient has it. Any destruction or whatever to say for the bone. So it's important to know what's going on in the bone. But the disease itself, and you have learned that from the genetic talks and stuff, that the disease itself goes on in the bone marrow. And so the bone marrow is in adults, is mostly in the spine, in the sternum, and in the pelvis. Because there is this trabecular bone and the nurturing niches of the bone marrow, which usually produces just regular blood, every line of blood cells, is also good for the myeloma cells. They like that because they get nutrition, they get oxygen, whatever they need. So they are mostly there. In the adults, in children, they still have this bone marrow also in the long bones, but we lose that in the long bones. We usually, within the bones, we have this fatty tissue. Yeah? So that's important to know, because most of the lesions also in myeloma take place in those areas where you still have hematopoietic tissue, hematopoietic bone marrow, but they can also go somewhere else. If that is of any biological or prognostic factor is not clear at the moment, we are thinking about that, but it's not clear yet. So you can also measure or image the bone marrow, and you can get functional information. That's what I meant with metabolism and with sugar uptake. That's showing how active the disease is at that site. So if you have a lot of this tracer there, it shows you that there is some activity going on. Starting with X-ray, the advantage, it's widely available. I mean, I also gave talks in Eastern Europe, and they have it. And I gave talks in Asia, they have it. So X-ray is, I mean, available nearly everywhere. It is the basis for all those, or for the the older classifications, like Dury-Salmon. You might have read that in your notes, and the Crab criteria. They all were built, because that was the standard at the time, were built on X-rays. Had a rather low radiation dose compared to those new radiation-based techniques. And the problem is that it's not very sensitive. I will show you an image for that. You can see osteolysis that are taking place, and if they are there, it's very important, but you miss a lot of osteolysis, and I will show you why that is. It has a rather low specificity, which usually is not a big problem, because you can repeat it and then you see if there's a change, which is, for example, just colon gas, which might look like an osteolysis, and a few minutes later it's gone. So not that big a problem. Several regions are not easy to see, because, as I said, sometimes this beam of X-ray goes through the body, and if it goes first through the sternum and then through the spine, you will have that projected over each other. Like if you put some slides over each other, you will see both, and you're not sure where the osteolysis is. But again, you can do one from one direction and another picture from the other direction, so we'll see. We'll get this information. It's rather long, the examination, because you have to put your limbs and your spine, your pelvis on those film or on those detectors, and that's not very comfortable for the patients, especially compared to the other techniques I will show you. And this is the reason why I say it's not very sensitive. I have to admit we know that for a long time. So you can see this trial was even before I was born. So I think it was very interesting. At that time, science was, I think, much more hands-on. And so they took a corpse from a person who said, you can use it for science, and they drilled holes into the bones. And then they filled it with water and performed an X-ray. And they found that you have to destroy 30 to 50% of this bone until you see something in X-ray. And I think that's too late. And I think you guys agree because there's a lot of nodding in the room. Therefore, we need better techniques. Computed tomography advantage, it's superior to X-ray because you don't get only this one picture from one direction, but the beam goes around the body and you get like images from every angle. We have low dose whole body protocols. The good thing is that the bone is very dense. So you don't need a high radiation to have a contrast compared to the other tissue around the bone. If you have more body weight, it might be a little bit more difficult, but still you can see much more with this CT than with the X-ray. You get 3D information, as I said, from every angle, and that's very important, especially for the spine when it comes to stability. If you want to know if there's an osteolysis, if there's a problem, how much you can lift, and the orthopedic surgeon always asks for a CT to get this 3D information because in a regular skeletal survey or X-ray, you cannot get this information. Follow-up is relevant. You can see not very good in the spine and the pelvis, but in the long bones, for example, those focal lesions, and I will come back to that again and again. Small tumors consisting of plasma cells that can grow or shrink or go away, hopefully. And you can see that on the background of this, here's this fatty tissue I said earlier. It's rather convenient because it takes about 3 to 5 minutes. You lie flat on your back, go into the scanner, come out. It's not this very narrow, long tube as the MRI. I will come back to that. So it's rather convenient compared to the other techniques. It was included in the new definition. There was a lot of discussion, not amongst the radiologists, but amongst the hematologists, because people say, oh, if we do now this high sensitivity investigation, I had a lot of discussion about that, maybe we treat our patients too early. But I have to say, if there's an osteolysis, why wait until you see it, until 30 to 50% is destroyed? So nowadays, most of colleagues agree that we should treat patient if we see, coming from smoldering myeloma, if we see there are osteolysis in CT. So it was included in the new guidelines. It is of prognostic significance. If you have more osteolysis, it's bad. I think that's not very surprising. Disadvantage is it has a little bit higher radiation dose. And we are talking about longer living myeloma patients, which is fantastic. And we should really also think about what is the challenge we have for those patients from a radiation standpoint. But all the advantages, in my view, really weigh out this disadvantage of the higher radiation. Maybe we can even do it just once a year or maybe even not that often to spare radiation exposure, but I think it's not that much more, and all the information we get out of it really are so important, I think, that we should do it, and I hope you agree with that. It has a lower sensitivity for the bone marrow. I always stress this, that the bone marrow is really the space where the disease takes place, and because where the bone marrow is, the hematopoietic bone marrow, there are a lot of trabeculae, so small like streaks of bone within the bone. It's like a sponge, and this is so dense that you see that in the CT and don't really see something else. And there comes the other techniques are important for that area. We have compared CT versus X-ray, and we found that 25% are missed. 25% of patients are missed if you do an X-ray compared to a CT. Again, you can say 25 is not all of them, but I think 25 is 25 too much, or 23.9. This is what we have done in Heidelberg and have just started to do that in Buffalo as well. It should work here. This is a so-called whole body low dose CT. You see, it's not really whole body, it's right below the knees, depending also on the height of the patient. But you can see we really get a very good impression. And we get additional information. We get information on the lungs, a little bit also on the abdomen. The problem there is that you have, it looks all the same, you don't have really contrast. And I try to avoid, and we discussed that yesterday with the radiologists here, we try to avoid contrast agents, which is also important because a lot of you might have problems with the kidneys, and you get a lot of drugs, of course, that have to go through the kidney and out of the body. So it's important, if you don't need contrast agent, you should not use some. And that's in CT because of the high density of the bone, and because the bone is the most important thing we are looking at in CT, you don't need contrast agent for that usually. We also looked where the osteolysis are. As I mentioned, most of them are in this axial skeleton, this reddish or orange area. But you also have others, like in the skull and in the long bones, so you can have them all over the place, but most of them are actually in the axial skeleton. Advantages of MRI. It doesn't need radiation. It shows the bone marrow infiltration before the bone is destroyed, and I think that's very important. I think Gareth already said that. Very important, you can see changes before the bone has been destroyed, and that's what we want to do. We don't want to wait until something bad has happened. We want to react earlier. It has the highest resolution for soft tissue, and bone marrow in certain ways also soft tissue, so that helps very much. It helps to a certain degree to differentiate between benign and malignant fractures, meaning you can have an osteoporosis because maybe you're an aged woman, I don't know the good words in English. I mean, we all get older, right? And so it's postmenopausal. And so you can have an osteoporotic fracture, and you can see, okay, if it's fatty marrow, then it's rather an osteoporosis because of hormone change, or you have a malignant fracture caused by myeloma. So it helps to differentiate that to a certain degree. Follow-up is relevant if you see changes, if it's increasing lesions again or shrinking lesions. That's important to get more information than we just get from the SPEPs and from urine serum. It was also included in a new definition. You have seen that earlier, that we treat patients, or at least we discuss, and I absolutely agree, we discuss with patients if we should treat them before the bone has been destroyed, because there's also a too early, which is really hard to really, maybe not to understand, but to accept for patients. And I have a lot of discussions with my patients with smoldering myeloma and even with MCRT, because they say, doctor, you know that there is something, why aren't you doing anything? So MRI helps at least to a certain degree to look how much is going on in the bone marrow, and in the whole bone marrow, not only where we put our needles. Disadvantage, it's inferior for the bone. You do not really see the bone. If there's a huge tumor, of course, the bone will have been gone, but you do not really see the bone, so you still need those radiation-based techniques. Some patients cannot have it because they have pacemakers, but modern pacemakers are also able to be investigated, or the patients can be examined in MRI, but some patients can't, and some just don't accept this long tube I mentioned. And it's not clear if you have residual lesions after therapy, if we should go on treating, and we have already heard that we might, but it's not sure right now, so the science has to really get further there. Advantages of PET-CT. I said this with this tracer, with the sugar that's taken by the cells and eaten by the cells, and then emits where the cells really sit. This is very good. It shows the metabolism. It might be high or low. So that's the FDG PET. FDG is this tracer I mentioned, this sugar. It is of prognostic significance. If you have a lot of those lesions, then it's bad. If you have less, it's better, which is, again, not surprising. It just reflects the tumor mass in the body. Same with the disease activity. They might be high and might be low. Disadvantages is you have also, this sugar can be taken up by immune cells that are just showing an inflammation at a certain part of the body. But usually the nuclear medicine people have some clue where it's rather malignant, where it's rather inflammation. It's cost expensive and depends very much on also the center, if it's available or not. So we have to work on really getting that more available for the patient. It has a little bit higher radiation dose because you add a CT usually. You want to see where those accumulations of this tracer are, and so you have some additional radiation dose. And now, very new, we can combine the PET with the MRI, so you have lower radiation dose, but then you miss the bone. So at the moment, I cannot say which one is really the best of the three, but I can say they're all better than X-ray. So again, I cannot stress this point enough. MRI. I mentioned those focal lesions, and sometimes you might have read that in notes or in the internet or in some information. Myeloma is a hematological disease, and usually you would expect that it grows in the bone marrow always in a homogeneous way, always the same. But that's not true. Some patients have this homogeneous pattern, or we call it diffuse pattern. Usually this is a lumbar spine, and those are the vertebral bodies, and between them are the intervertebral discs. And usually they should be, I say, a lighter gray scale, because when we are getting older, we have more fatty marrow, and fat is lighter or white, as you can see here on the back. But in some patients, you can see this normal-looking bone marrow and some spots that are darker, and those are the myeloma cells. We have put needles in it, and it's really myeloma cells, and Garrett's group has done that also. So that's something we don't really know why. Some patients have those focal lesions, some have the diffuse infiltration, and some even have both. They have a mixed pattern. We are not sure about the reasons why some of this happens. In MCRT, it's rather low, the part of focal lesions, and this is actually a rather high number. Usually you have less, but we just counted what we saw, and it can also be something else. But in symptomatic myeloma, the percentage of patients with those focal lesions is much higher. So it seems to be correlated to some more advanced disease. They are of prognostic significance. Those are the curves we look at. Every step down is a patient who had a progression, and you can see a normal-looking bone marrow is, from a prognostic point of view, better than this nodular or focal compared to the diffuse and the mixed pattern. So we don't change our treatment based on that, but still it's an interesting finding, and we are still trying to figure out what's going on there, why some develop this and some don't. We can treat patients earlier, and we have looked into smoldering patients, and if they had focal lesions and the cut point was more than 1, you can see those steps down are coming earlier. So this is a sign of maybe a myeloma, a smoldering myeloma, that might benefit from an earlier treatment. But it's also important, if you're not sure, if the doctor is not sure if this focal lesion is really myeloma, you should repeat it, and we have done that in a trial. We have seen if those focal lesions are there, but they stay the same in size and number, then it's not really a bad prognostic factor. You can see it's just changed, so a step up means a patient is progressing. So that's not really very much going on. But if you see that the size increases or the number increases, then it's a very bad prognostic factor. So there's some dynamic, there's cancer with dividing cells. You see a lot of those patients really progressed early and needed treatment right away. And so we look, sometimes if we are not sure, we just repeat the examination, and if there's some dynamic, then we would treat the patient. And it's very important because this shows all the patients we examined that were progressing, and we put here the CRAB criteria, CAR and B. You have heard bone disease, anemia, and so on. And all those small b's you might not even see. Most of those patients were really progressing with bone disease. So you can kind of predict, not really, but kind of predict the bone disease. And here's one patient of mine from Heidelberg, and we did a CT and an MRI, and it looked good. It was smoldering myeloma. We didn't treat the patient. Then we did a follow-up. So this is just a zoom. And we did a follow-up, and we found, oh, there's a focal lesion. It's another technique. So this white spot is the focal lesion. And then we went back to the earlier MRI, and we found, okay, this focal lesion was already there. So this is this dynamic I talked about. And you can see here, then we performed the CT to look at the bone, and actually has developed this osteolysis. So maybe we should have treated earlier, but at that time we were not sure about that. So very important, if you're not sure, repeat the examination and do not force the treatment. This is what I said about differentiation between malignant and benign fractures. This is just for us to really see what's going on if the fracture is really caused by the multiple myeloma. And it's, again, not 100%, but it gives us some information. Treatment monitoring. A very, very good message is when I started treating myeloma patients, I was told myeloma osteolysis never go away. That was true at that time because in X-ray you do not see a positive change. But since we do CTs, we see that at the margin, not every osteolysis, I'm sad to say that, but some osteolysis really develop this so-called recalcification where the body tries to heal this osteolysis. And I have patients, few patients, but I have patients that are in long remission, and they really, the osteolysis, small osteolysis really went away. So I cannot promise anything, but we are getting better. We are getting better with treatment, and we are getting better with diagnostics, and that's the good news. We looked, if you have, after treatment, you have, and you mentioned that already, Gareth, that if you have residual lesions after therapy, you have an adverse prognostic significance. So no residual lesions is better than a lot of residual lesions, which is not, again, not surprising. And here again, those curves, and you can see the blue patients had not osteolysis, but those focal lesions left, and the yellow ones had some left, so they progressed earlier. It's not a huge difference, but there is a difference, so we can learn something about that. And I think it's very important to see, you already heard about this minimal residual disease, which we can diagnose out of the bone marrow. And it was also already mentioned that it's good to do this bone marrow biopsy to see if there's, with very sensitive techniques, if there are some plasma cells left. But the problem is if those plasma cells are not here and we put the needle here, we might miss them. So the combination of both is much better, to do a whole body imaging to see where the cells are and do the bone marrow biopsy to see if we don't see something else, if it's really, really low, because imaging will miss a lot of smaller amounts of cells, of course. And then this is what we think that's going on. This is, again, a focal lesion, and there we might have MRD positivity. And if you put the needle somewhere else, you might have MRD negativity. So it's important to combine imaging with those bone marrow examinations. And this is when you combine it, double negative is better than just one negative. Again, not really surprising. Just very briefly, what's going on, because you will hear much better talks about that later on. As I said, we can combine PET with MRI. There are a few scanners in the country. It's getting more and more, which is very interesting and very exciting. We can use a so-called diffusion-weighted imaging. That is, if you have a lot of cells, the water molecules, I mentioned MRI measures water movement, and the water can move, and cells restrict the movement of the water. And if you have a lot of cells, the water cannot move that far. And if you have fewer cells, a lot of cells means cancer, fewer cells means maybe less cancer. The water can move further, and you can differentiate that. And this is how it looks like. It looks like a CT scan. Those white spots are areas where there are a lot of cells, and this is after therapy, and there are just a few of them left. So this is kind of a nice new technique to use. And we try to use, someone asked about technology, we try to help the radiologist, because a whole body MRI has, I think, 3,000 images, and the radiologist always says, yay, 3,000 images. And so we try to help them, and we try to help automizing that, let the computer do the heavy lifting. And you can see here, this computer really found those lesions. We are not there yet, but we are developing that. So in summary, if you have an MCRT, we want to exclude osteolysis. We want to be sure you don't have osteolysis. So in smoldering, we also want to be sure you don't have osteolysis and you don't have focal lesions. that might eventually develop into osteolysis. If you have newly diagnosed multiple myeloma, we also want to see if you have osteolysis, where they are. We want to see if there are focal lesions reflecting your tumor mass. We want to see if everything is stable, if the cord, the spinal cord is not compromised in any way, and if you have soft tissue tumors. And if the disease comes back, so-called relapsed and refractory multiple myeloma, it's the same questions as in newly diagnosed. So what do we do in MCRT? I would recommend, it's not really approved yet, but I would recommend to do a CT to exclude the osteolysis. Also, if you need in follow-up, if there's pain or something going on. Smoldering MRI, because we want to see it earlier. If there are focal lesions, then we would do the CT to see if there are also osteolysis. Same in follow-up. PET CT is also very valuable there. In newly diagnosed myeloma, PET CT is very good because you also get an impression of the activity of the disease. Same at first diagnosis and also in follow-up. And later on, you try, at first diagnosis, the tumor mass is highest because you haven't known that there is a disease. When you have the diagnosis, then you know what you have to look for. So we catch the disease earlier, so we need a higher sensitivity, and I would recommend to use the MRI, but you can also use a PET CT or even a CT there to get the really clinically relevant information. With this, I thank you for your attention. Sorry I talked too long.